Are you gearing up for radiology board exams? The Radiology Review wants to save you money. Visit our discount code section for current offers on Radiology Review recommended educational resources. Head to theradiologyreview.com and navigate to the discount code section. Terms and conditions apply. Limited time offer. Discounts may vary. Welcome to the Radiology Review podcast with your host, Dr. Matt Covington, a board-certified radiologist. For additional content, please follow the Radiology Review on social media, such as X or Instagram, at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website, theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will discuss Li-RADS, which is the Liver Imaging Reporting and Data System, and we will focus on content pertaining to diagnostic Li-RADS evaluation. It is my understanding that a treatment response Li-RADS update is anticipated in late 2024, and I would encourage you to refer to that for the treatment response associated Li-RADS information. But for this episode, we will focus on Li-RADS for diagnostic CT and MRI liver imaging. I checked, and this is included in the ABR core exam content available in the ABR issued study guide online. And I think content such as BI-RADS, Li-RADS, or other forms of RADS are high yield for multiple choice style board exam testing, especially because it is relatively easy for test writers to write multiple choice questions based on things like BI-RADS or Li-RADS criteria. Remember to check out my website, theradiologyreview.com, where a free downloadable study guide on this topic will be made available to you once this episode is posted. And while you are there, check out the discount code sections of my website, where you can find discount codes on educational content, as well as other offerings that may be of interest to you. And without further ado, let's get into the questions and answers for this episode. First question. What is the overall point of Li-RADS? The Liver Imaging Reporting and Data System, which I will simply abbreviate as Li-RADS going forward, and make sure not to confuse this with any other RADS such as BI-RADS or TI-RADS or PI-RADS. Li-RADS exists to categorize CT and MRI imaging findings in terms of the risk of a finding being a hepatocellular carcinoma, which I will often simply describe as HCC for hepatocellular carcinoma. Whereas BI-RADS exists to categorize breast lesions in terms of risk for all primary breast cancers, Li-RADS is specific for hepatocellular carcinoma risk and does not specifically apply to other types of primary hepatic malignancies. Next, what is the difference between an observation and a lesion or nodule in Li-RADS? According to Li-RADS, a focal abnormality seen on imaging is technically a, quote, observation, as these may or may not represent a true lesion or nodule. For example, a perfusion anomaly may appear as a, quote, lesion or, quote, nodule on imaging, but is in fact not. So the term observation is used instead. Next question. What are major features for diagnosis of hepatocellular carcinoma on CT or MRI according to Li-RADS? Major criteria for diagnosis of HCC on Li-RADS include internal arterial hyperenhancement above background liver enhancement, followed by internal washout of enhancement relative to background liver on the portal venous and delayed post-contrast phases. Additionally, an enhancing capsule that appears as a peripheral rim of smooth hyperenhancement is also a major feature of HCC. Another major feature of HCC is a diameter increase of at least 50% in 6 months or less, but this only applies if the imaging finding is that of a mass and not something like aberrant perfusion. I would make sure and review that so you are very clear with the major criteria of HCC in Li-RADS, and if helpful, download the free study guide on this topic to review it in writing. Next question. On which phase of enhancement should an HCC be measured? A hepatocellular carcinoma should be measured on whichever sequence best illustrates mass margins and should be measured outer edge to outer edge. In general, measuring an HCC on arterial phase imaging or other sequences like diffusion-weighted imaging is discouraged as margins are not typically best seen on these sequences. When comparing size measurements over time, make sure to always compare measurements obtained on the same post-contrast phase. For example, don't compare measurements made on a portal venous phase to a subsequent measurement made on a delayed phase sequence. Next question. If pathology results are available, should a Li-RADS category for that finding still be reported? The answer here is mostly no, but partially yes. Let me explain. If the diagnosis is histologically proven, the pathological diagnosis is reported without a Li-RADS category. However, if the biopsy lesion remains uncertain or is a precursor lesion to HCC, such as a dysplastic or regenerative nodule, both the pathology diagnosis and the Li-RADS score should be reported. Next question. True or false? Hepatocellular carcinomas can show internal fat. The answer here is true. While not specific for HCC, internal fat is a feature that can be seen with hepatocellular carcinoma and is a feature that favors hepatocellular carcinoma compared to many other hepatic masses. Internal fat greater than adjacent liver is reported to be an ancillary feature that favors hepatocellular carcinoma versus other hepatic malignancies. Next question. What are ancillary features of a hepatic mass that favor that the mass is benign rather than a hepatocellular carcinoma? Features of a hepatic mass that favor a benign entity rather than a hepatocellular carcinoma include stability or reduction in size of the mass over at least 2 years or greater, as well as marked T2 homogeneous internal hyper or hypointensity, which are both features that favor a benign mass rather than a hepatocellular carcinoma. Additionally, marked and homogeneous T2 star hypointensity favors a benign mass rather than a hepatocellular carcinoma. So in general, you can remember that either marked T2 homogeneous hyper or hypointensity as well as marked and homogeneous T2 star hypointensity favor a benign mass rather than a hepatocellular carcinoma. Additionally, a mass that mirrors blood pool enhancement levels and or a mass that is isointense on hepatobiliary phase sequences is favored to be benign. Next, what are the imaging features that would categorize an imaging finding as Li-RADS 1 in Li-RADS? Category Li-RADS 1 represents a 100% benign lesion. Imaging features diagnostic of a benign entity include a benign hepatic cyst, hemangioma, perfusion alteration, focal scar, and confluent hepatic fibrosis. Lesions that definitively disappear at follow-up without treatment are also considered Li-RADS 1. Next, what is the imaging appearance of confluent hepatic fibrosis? Confluent hepatic fibrosis is a Li-RADS 1 lesion, typically seen in a cirrhotic liver, confluent hepatic fibrosis is most common in the medial and anterior segments of the liver, involving hepatic segments 4, 7, and/or 8. Confluent hepatic fibrosis often appears wedge-shaped, radiating from the porta hepatis out to the capsular surface, with the largest extent of involvement seen peripherally. Mild capsular retraction or a mild concave peripheral margin may be seen. Given the fibrosis, this should show progressive enhancement, most pronounced on delayed phase images on CT or MRI compared to normal liver background. On CT, areas of confluent hepatic fibrosis typically appear hypodense on non-contrast imaging. On MRI, areas of confluent hepatic fibrosis typically appear moderately T2 hyperintense with no internal fat signal intensity. While confluent hepatic fibrosis and cholangiocarcinoma can both show capsular retraction, cholangiocarcinoma shows arterial hyperenhancement and generally appears more mass-like than does confluent hepatic fibrosis. Lastly, intrahepatic biliary ductal dilatation is more commonly seen with cholangiocarcinoma than with confluent hepatic fibrosis. Next, how does a category Li-RADS 2 finding differ from a Li-RADS 1 finding in Li-RADS? Li-RADS 2 lesions are, quote, probably benign, whereas Li-RADS 1 lesions are 100% benign. Li-RADS 2 includes entities that are highly suggestive of being benign but lack full diagnostic certainty. Atypical appearances of benign entities and cirrhosis-associated nodules also fall under Li-RADS 2. Next, what are imaging features of a Li-RADS 2 cirrhosis-associated nodule? To be classified as a Li-RADS 2 cirrhosis-associated nodule, all of the following imaging findings must be present. Diameter less than 20 millimeters, but be distinctly larger than background cirrhotic nodules. Homogeneously enhances the same as background cirrhotic nodules in all phases. Differs from background cirrhotic nodules by having up to moderate hyperattenuation on CT, having up to moderate T1 hyperintensity, and or having mild, moderate, or marked T2 or T2 star hypointensity. Next, what are features that define a category Li-RADS 3 finding in Li-RADS, and why is it considered intermediate probability for hepatocellular carcinoma? Li-RADS 3 indicates an intermediate probability of hepatocellular carcinoma. It includes entities that are neither definitively benign nor definitively HCC. Imaging features can include no definite mass or a mass with ISO or hypoenhancement during the hepatic arterial phase, a mass smaller than 20 millimeters with no more than one suspicious feature defined as non-peripheral washout, a distinct capsule or threshold growth, which was previously described as at least a 50% increase in size in a 6-month period or less. And I think that is one key bit of information to remember with Li-RADS is the threshold for suspicious growth. And once again, that is an at least 50% increase in size in 6 months or less. Finally, a Li-RADS Category 3 mass can be a mass with arterial phase hyperenhancement under 20 millimeters without additional major features of washout, a distinct capsule, or meeting the growth thresholds just described. Li-RADS Category 3 to me is a little bit tricky. I would recommend reviewing this content again, perhaps in writing if helpful for you. Next, what are the key characteristics of a Li-RADS 4 mass in Li-RADS, which are considered probably HCC? Li-RADS 4 indicates a probable hepatocellular carcinoma. These are divided into two major diagnostic decision trees based on whether a mass has no arterial phase hyperenhancement or shows non-rim arterial phase hyperenhancement. First, for masses with no arterial phase hyperenhancement. If no arterial phase hyperenhancement is present, the mass needs to measure less than 20 millimeters with two or more of these features: non-peripheral washout, an enhancing capsule, or threshold growth. If the mass is over 20 millimeters, any one of the features just described is sufficient for Li-RADS 4. Now on to the second decision tree, which is masses with non-rim arterial phase hyperenhancement. If the mass measures less than 10 millimeters, you would need one or more of the following: non-peripheral washout, enhancing capsule, or meeting threshold growth of at least 50% size increase in 6 months or less. If the mass is 10 to 19 millimeters, the mass must show an enhancing capsule but does not show washout or meet threshold growth. If the mass is at least 20 millimeters or larger and has no other major features such as non-peripheral washout, an enhancing capsule, or a meeting threshold growth. Similar to Li-RADS 3, Li-RADS 4 is also a bit complicated and is worth your time reviewing again, either by rewinding what I just said or referring to my study guide or other information that may be available to you. And finally, what defines a Li-RADS 5 mass in Li-RADS, and how is a Li-RADS 5 mass certain for hepatocellular carcinoma? Li-RADS 5 is 100% diagnostic of hepatocellular carcinoma. As a reminder, Li-RADS 1 is 100% a benign lesion, and now Li-RADS 5 is 100% diagnostic of hepatocellular carcinoma. A Li-RADS 5 constitutes a mass that presents with non-rim arterial phase hyperenhancement. If the mass measures 10 to 19 millimeters, if there is an enhancing capsule, this mass must also show non-peripheral washout and meet threshold growth of at least 50% size increase in 6 months or less. If there is no enhancing capsule, then either non-peripheral washout or threshold growth is sufficient. If the mass is at least 20 millimeters or larger, one or more of the following must be present: non-peripheral washout, an enhancing capsule, or threshold growth. That constitutes a review of Li-RADS 1 through 5. And to go through those very quickly again, Li-RADS 1 represents a 100% benign lesion. Li-RADS 2 lesions are probably benign. Li-RADS 3 lesions are intermediate probability for hepatocellular carcinoma. Li-RADS 4 lesions are probably hepatocellular carcinoma. And a Li-RADS 5 mass is 100% diagnostic of hepatocellular carcinoma. There are now a few special Li-RADS categories that we will review. First, what is the Li-RADS M category, which is M like the moon? What is Li-RADS M category? Li-RADS M is used for hepatic lesions that are at least probably malignant, but show an appearance unlikely to be a hepatocellular carcinoma. For example, a highly infiltrative hepatic mass or masses with marked restricted diffusion on MRI. These are suspicious findings for hepatic malignancy, but are unlikely to be hepatocellular carcinoma, and could be appropriately categorized as a Li-RADS M category lesion to communicate this in Li-RADS terms. Next, what is the Li-RADS TIV, which is short for tumor in vein category? If there is enhancing soft tissue that unequivocally invades the portal vein, whether due to hepatocellular carcinoma or other hepatic malignancy, Li-RADS TIV should be included to indicate this contraindication to liver transplantation. Next, what is category Li-RADS non-categorizable, which is shortened LRNC. LRNC, or Li-RADS non-categorizable, is used when the technical quality of imaging does not allow evaluation of major imaging features of hepatocellular carcinoma. For example, imaging that does not contain the required phases of enhancement would be categorized as Li-RADS NC. And that is the last question for this episode. A few additional notes that I would like to include are as follows. First, there are many ancillary imaging features of benign or malignant hepatic masses that are not fully addressed in this episode because there are so many of them. These can include things like coexisting findings on ultrasound, the presence of iron or blood products within a mass, and so forth. However, Li-RADS is primarily driven by the major criteria of hepatocellular carcinoma, which are described in this episode. I think it is less likely that the core exam will test you on the variety of ancillary features versus the major criteria. For this reason, I have focused on the major criteria in this episode. I would remember, however, that ancillary features come into play for findings that are equivocal between Li-RADS categories. These ancillary features can be used to upgrade or downgrade a lesion by one Li-RADS category, depending on whether ancillary imaging features are potentially concerning or reassuring. It is also important to remember that while ancillary imaging features can upgrade or downgrade an imaging finding by one Li-RADS category, such as Li-RADS 3 to Li-RADS 4 or Li-RADS 4 to Li-RADS 3, ancillary imaging features can never upgrade a Li-RADS 4 mass to Li-RADS 5. That concludes my brief review of Li-RADS. Visit theradiologyreview.com to download the free study guide on this episode and check out other content while you are there. I hope this episode was helpful for many of you. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
Hey listeners, have you checked out our Instagram page? It's a great resource for daily facts. Follow us at RadRev Podcast.